Good morning and welcome to the North Dakota Department of Health Town Hall on COVID-19, and more specifically, today we're going to be talking about the Omicron variant. We have three great speakers with us today, and so I'll start off by introducing them and they will each present, and then at the end of the town hall we'll have time for some question and answer sessions. So our first speaker today will be Dr. Paul Carson. Dr. Carson is an infectious disease physician and professor of practice in the North Dakota State University Department of Public Health. He has over 25 years of experience in various clinical capacities and works with the North Dakota Department of Health on many projects, including projects related to healthcare-associated infections, antimicrobial stewardship, and vaccination. Our next speaker today will be Kirby Kruger, who is the Section Chief of Disease Control and Forensic Pathology at the North Dakota Department of Health. Then I will be speaking. My name is Molly Howell, and I'm the Immunization Director for the North Dakota Department of Health. And then last but not least is Tim Wiedrich, who is the Section Chief of Health Resources and Response for the North Dakota Department of Health. So I think I should also mention that none of our presenters today have any financial relationships to disclose with pharmaceutical companies. So next, I think we'll get started, and Dr. Carson is going to give us an update on COVID and the Omicron variant. I'll turn it over to Dr. Carson.
Good morning, everyone. Thank you, Molly. So I'm going to share my screen and walk through a few slides for some of the information that I want to present on this morning. So I kind of titled this, "What can we expect with Omicron and where are we at with Omicron?" For those of us who follow these variants of concern, the Omicron variant emerged here just late last year, first identified in South Africa. And what was concerning about this is that it has a little over 50 mutations in the virus. These are where the protein structure of the virus changes a little bit over time. There was about 50 of these, 30 of which were in the spike protein, and a good chunk of them, around 15, in what's called the receptor binding domain, which is the part of the spike protein that attaches to our cells. And there was concerns that those changes might make the virus more transmissible or faster at being able to spread from person to person, and it might make it able to escape immunity that we've developed either from prior vaccination or prior infection. And unfortunately, both of those things have turned out to be true. So we have some good data coming from places like the UK and Denmark that have had an earlier surge of this than we did. In a study out of Denmark, it found that the Omicron variant is about 3 times more likely to spread to household member contacts, for example, than the Delta variant. And recall that Delta was already about twice as likely to spread to other contacts as the earlier variants like Alpha and the original strain. So this is way more contagious, just far more contagious than our earlier variants. And we've seen that now take off in the United States. So this is these bar graphs by date give an idea of what were the predominant variants in the United States. And so you can see all through October and November, it was almost all this orange, which is Delta. But starting in the middle of December, Omicron started to appear in the United States, and within just a few weeks has now become the by far dominant strain in the United States, with over 98% of the identified strains being due to Omicron. So it's really pushed out and replaced the Delta variant. And that's had the expected effects, actually in maybe bigger numbers than we might have anticipated. So you can see the daily new confirmed cases in the United States with our earlier waves, like with Alpha and with Delta. And we thought we were being hit pretty hard, and we were being hit pretty hard when we were seeing, for example, last winter, up to 300,000 cases a day being identified, and now we've had recent counts over almost 1.5 million cases in a single day. So this has just exploded in the number of new cases throughout the United States. And in North Dakota, we are now starting to have that surge here as well. So we're right on the front end of our Omicron wave moving into the upper Midwest, and we're really now starting to see it take off in North Dakota. A lot of questions have been around, is this less severe or not? And we're getting more and more information that gives us some sense of that. And first I should say, if it is less severe, it can be from one of a couple of different reasons. It can be from intrinsic factors, meaning things about the virus itself that make it less severe, or it might be from extrinsic factors, such as more of us being immune now because more of us have been vaccinated and more of us have had prior infections than earlier points in time during the pandemic. So we just might have a lot more people who are immune, which makes it look less severe. So here's some of the data that's coming out on this. This is some data from the Kaiser Permanente system in Southern California. They partnered up with UC Berkeley and looked at the rates of symptomatic hospitalization. So the purple is kind of earlier variants. This is like the percentage of people who had a hospitalization with symptomatic disease versus the green, which is Omicron. And you can see about a 53% reduction in symptomatic hospitalization, about a 74% reduction in ICU admissions, and about a 91% reduction in mortality. This is pretty early. It's a little early to be counting our mortality data because that is what we call a lagging indicator. Some other data out of Europe suggests that kind of similar decreases in the virulence of the virus, and about half of that effect is maybe because of prior immunity. At least I'd say about half of it is due to more people being immune, and about half of that lowered effect is because of maybe some intrinsic decreased properties of virulence in the virus itself. And this has led to what some people call decoupling of the cases, the enormous numbers of cases, and the severity of the disease. So this is looking in London, where it was hit very early on in Europe, and looking at the peak of their cases during the alpha wave. So like 100% of, meaning 100% of peak was during alpha, and kind of looking at the subsequent waves in relation to the highest wave they had previously had. And you can see they moved into Delta in the middle to late summer at much lower levels of cases in green, hospitalizations in blue, people on the ventilator in orange, and deaths in red. But you see, as they move into the Omicron wave, it really took off, far exceeding the number of cases during the highest previous wave of alpha, but much less hospitalizations, people on the ventilator, and people dying. Now, this is starting to uptick a bit more in London and England now as more data is coming in, but it still looks like it will come in substantially lower in relation to the number of total cases than it did with the alpha wave, or their worst wave. Now, is that holding up, and is that true everywhere? Well, that isn't quite what we're seeing in the United States. So here's the cities that have been hit the earliest in the United States. New York, Washington, D.C., and Chicago are some of the bigger metropolitan areas that have had some of the earliest surges in Omicron. And you can see, compared to our, those cities' biggest peaks here, 100% earlier, again, that's probably with the alpha wave. You can see we've exceeded the number of hospitalizations. We're just about close to the peak of people in the ICU, and about halfway there to people who are on ventilators. Similar in Washington, D.C. and in Chicago, they've actually already matched the number of people in the ICU and on ventilators than what was seen with the previous peak at the worst of the pandemic in the earlier waves. So we don't seem to have this decoupling, at least in the earliest signs in the United States, that they've seen in Europe and in some other places in the world. Now, why is that? It probably has to do with the degree of immunity that's in the United States. This is a very nice graphic that was published in the COVID articles that are put out in the Financial Times from the UK. They call this sort of a graphic of the immunity wall. So this looks at different age groups, 16 to 24, 25 to 44, and so on, and how many of them have had infection or vaccination or both. And of course, the more of those things that you've had, the more immunity that you likely have. And you can see in England, when you look at immunity 3 doses plus being infected is probably the most immune persons out there. 2 doses plus an infection, previous infection, the next most. 3 doses, the next most. 1 dose plus an infection, the next most, and so on. And the red being people who've never had any infection or vaccine. And you can see that in England, there's just not that many people left that haven't had some degree of immunity there. And a lot of the people have had these sort of darker blue, meaning more exposures to vaccine doses or vaccine doses in the virus. You contrast that with the United States, and we just have a lot more people that still haven't had either a vaccine or had prior infection. And so we have more exposure to what we call immunonaive, or people that have no protection or minimal protection, like 1 dose only, or only a prior infection, or only, and then the 2 doses and not boosted. So, and if we were to add the age groups of 5 to 11 and 12 through 15, we'd even see more red here in the United States than we see in England, because we have a lot less vaccinated children than a lot of the European countries do. And that probably is why we're seeing so much more spread and maybe more severe disease in the United States. One of the things that I'm a little bit concerned about is what this is seeming to be doing to children. So children, for the most part, are still fare much better than adults when it comes to the virus in general, and probably Omicron as well. But the attack rate is just so much higher with this, that the infectious spread and the number of people, including children, that are getting infection is just so much higher that we are seeing a commensurate increase in hospital admissions in children. So this is hospitalization rates per 100,000 kids in children ages 0 to 17. And you can see, compared to our earlier waves of Alpha and Delta, it's just much higher. Now, this is still, if you put this in comparison to older age groups, it's still much lower than older age groups. But relative to kids in general, we are seeing more than we saw before, and we're hearing that now from most of the health systems, that they are admitting more children now with Omicron. And Delta and New York has put out some more granular data on this with age breakdown, and you can see that most of those pediatric hospitalizations are in that 0 to 4-year-old age group, and those children are not eligible for vaccination, which probably explains why they're the highest group being hospitalized. And of those children that are eligible for vaccination, the 5 to 11 and 12 to 18, New York reports that about 91% of the hospitalizations in children that are occurring recently are in the unvaccinated, 91%. So this is a concern for unvaccinated children in particular. One of the questions is the vaccine really doing anything? So will the vaccine protect me against Omicron? And we're getting more and more data on this now. So here's some recent data that just again came out of that Kaiser Permanente Southern California health system, looking at how well the vaccine protects, or vaccine effectiveness, against the earlier Delta variant. And we knew already, at least against infection. So note what I'm saying here. We're talking about infection in general, and this is typically symptomatic infection. The vaccine early on was protecting very well. So this is days from your vaccine. But as you got further and further out from your second dose, that protection, even against Delta, was dropping to around the 50% mark. Now that's still, it's a good thing to cut your infection risk in half, but we saw that when you're getting out to 9, 10, 11, 12 months out from your vaccination, that that vaccine efficacy was falling to about that 53% mark. It's much worse with Omicron. So by the time you're out around 6 months out from your vaccine, the vaccine really wasn't protecting anyone, or very little protection against infection. And we're seeing this in North Dakota. So this is the number of cases in unvaccinated people, which always ran higher than the vaccinated, and this isn't adjusted for population. We have most of the population is vaccinated in the United States, so this is unadjusted for. I'm sorry. This is adjusted. Never mind. This is per 100,000 each of these groups. But we can see now with Omicron that it really doesn't matter if you're vaccinated or not with getting an infection. That's with 2 doses, what we consider full vaccination, 2 doses. Here is some of that same data from the Kaiser system with 3 doses of the vaccine. So this is, and here they were looking at Moderna, which is typically a little bit higher than Pfizer. And you can see 3 doses was very protective against Delta, and that's still a good thing. Delta is still potentially out there, and Delta is more virulent than Omicron, so it's a good thing if we can prevent Delta still. And 3 doses of vaccine was remarkably good against infection. And note again what I'm saying, because we'll get to severe illness here in a second. So against infection, very good against Delta. And 3 doses give some protection against Omicron, about a 50% protection. So you cut your risk of infection in half, even against Omicron, if you've had a booster or 3 doses of the vaccine. We care most about severe illness. So again, kind of summarizing some of that symptomatic infection data by dose and looking more specifically at severe illness. We're getting some data from the UK, we have some data from South Africa, and a little bit of data from the United States. And so even with 1 shot early on, so right after that first shot, you get some protection. The UK saw a 26% decrease in infection rates in people who had recently gotten their first shot of the vaccine. So if you're unvaccinated and you say, well, Omicron's here, what good's it going to do me? Actually, it might do you some good. And they even saw a greater benefit, even from 1 dose against severe illness, about a 52% reduction in severe illness right after starting that first dose. 4 weeks or more after starting that first dose. So it's still worthwhile to start a vaccine now in hopes of preventing severe illness and even some protection against symptomatic infection with Omicron surge. I pulled out the 2-dose data out past 25 weeks. So most people who are vaccinated have been vaccinated for a while now. So if you get further out from that vaccine, we know that the effectiveness of it falls off. And as I showed with that Kaiser Permanente data, the UK and South Africa showed almost no protection, only a 2% reduction. So almost no protection against symptomatic infection. But if even 2 doses, there was a 52 to 70% drop in severe illness from Omicron. So what we call full vaccination in the United States, 2 doses, still was giving pretty good protection against severe illness. If you bump that up to 3 doses of the vaccine, even more protection, bumping up the protection against symptomatic infection. It ranged from 28% to 63%, depending on the country and depending on how far out you were from your vaccine. But almost a 90% decrease, and this is being seen everywhere that's looking. It's kind of holding up pretty good. 3 doses had about a 90% reduction in severe illness. So that's a good thing. Boosted people have a very high level of protection against severe illness, which usually means hospitalization or death. And we've got some other data that's kind of looking at this in a different way. So even if you do break through, you get a breakthrough infection, and you're sick enough to get a breakthrough infection that lands you in the hospital. So that's a vaccinated person who got a breakthrough infection and landed in the hospital. That's actually a very rare event. It does happen. We have handfuls of cases of this. But if you are vaccinated and you happen to land in the hospital, your length of stay in North Dakota with recent data is going to be about 5.4 days, compared to the unvaccinated person who lands in the hospital has about on average a 13.5 day length of stay in the hospital. So vaccination, even if you do get sick and even if you land in the hospital, tends to help you fare better from that hospital course. And I just would remind people that we have data on vaccine effectiveness against hospitalization. So severe illness with Delta stayed high, was just flat, staying high at about a 90% protective level against Delta. That's still a good thing. We want to maintain that high level of protection, and that's 2 doses. So high level of protection still is out there against Delta. I frequently will get questions about, well, what about natural infection? So I've already had COVID. How protective am I against the Omicron variant with prior infection? The Imperial College of London was able to do analysis on England's public health data. They have everybody's sort of in their national health database, so they're able to mine data very, very effectively. They found that reinfection was occurring at about 5.4 times higher rate than people who were going through the Delta wave. So it's just way more likely to break through. Prior infected people did have some reduction in risk for infection from Omicron, but it was only about 19% reduction in risk. Similar to people who were 2-dose vaccinated, they had about a 69% reduction in hospitalization. So they're fairly comparable, maybe slightly better, but fairly comparable to someone who's had a 2-dose vaccine series. I highly encourage people who've had a prior infection to at least consider getting 1 dose. There's no reason not to get, the full vaccine series that's been shown to be safe in people also who've had prior infection. But even 1 dose of a vaccine after prior infection gives very strong immunity and probably bumps them up to being pretty similar or equivalent to that 3-dose boosted vaccine person. So to summarize some of this data, Omicron is extremely contagious. It's spreading very quickly in the US and is now surging in North Dakota. It does seem to be less virulent, although some of that virulence has to do with more people being immune through vaccination and prior infection, but it has a very high attack rate. It's going to find those of us who haven't had any immunity from prior infection or vaccination before, and it's going to cause a lot of us who have been vaccinated, frankly. It's going to cause a lot of us to get a cold, or what I call an Omicron cold or a flu-like illness. The vast majority of those people who get that are going to stay out of the hospital and not have severe illness. And this is so even though it may be less virulent, a low percentage of a very high number of infections can be a very high number of problems, of hospitalizations and even deaths. So this is stressing and is going to further stress our healthcare system substantially. And finally, vaccines, especially 3 doses, are still good at preventing severe illness, and they somewhat decrease the risk of infection overall. So it's not true that they are worthless against infection, but boosted people have some protection there. And it's not too late to start vaccination now or get boosted if you haven't been boosted. We do not have enough people boosted in North Dakota. We really need to bump those numbers up. So I will stop there and turn it over to the next speaker.
All right. And thanks, Dr. Carson. And now we are going to turn it over to Kirby Kruger to give an update on COVID and Omicron in North Dakota.
All right. I don't know if you can see my slides or not. Okay, we're good to go. All right, thank you very much, Molly. And I just want to, first of all, just extend my appreciation for everybody who's taken time out of their day to attend the town hall today. My update today is going to be just talking a little bit about the epidemiology of what's happening in North Dakota with COVID-19 cases. Talk a little bit about variants and variant surveillance. We'll go through the updated isolation and quarantine guidance that came out from CDC recently. And I'll talk a little bit also about influenza as we move through the presentation here at the end. So just to start out with, I got to figure out how to advance my slides. I'm not very good at this, I'm sorry. So. All right. So just briefly, just a little bit of transparency here. On January 11th, we reported out 1,610 cases on our dashboard, and that reflected the Monday totals for testing. That was actually an underreport. We experienced some technical difficulties with our system for reporting numbers, and the actual numbers of new cases that should have been reported out that day was actually 2,120. Those numbers are in the dashboard now, and if you go to the trends, and look at the epi curve at the bottom, the cases reported by day, you'll actually see those. And just moving on with a quick update for cases. This is yesterday's update, and yesterday we were at 6,062 active cases, which are increasing sharply. As Dr. Carson indicated, Omicron is a very infectious disease and spreads rapidly, and so we are seeing very rapid increases, but also noting that our positivity is also increasing with our testing, and you can see the 14-day average for our positivity is now over 14%. And I was alluding a little bit to the epi curve, and there's two graphs here, and they're both from the same graph. The insert there is the overall epi curve for COVID-19 in North Dakota since the beginning of the pandemic. You see the first spike that occurred there. Our first spike occurred in November of 2020. It was pre-alpha, so it was one of the earlier variants that occurred. And you can see the spike we're at now at way on the right-hand side of that insert. We're now exceeding our spike that we saw in November. In fact, yesterday we set a single-day case reporting record, and so our cases are increasing rapidly. The larger graph shows just the detail of the last several weeks for the cases reported by day, just so you can get a little bit better look at that. And you can see this week, Monday and Tuesday, that we exceeded 2,000 cases, and we will exceed that again today. So cases rising very rapidly. Just looking at hospitalizations, our hospitalizations sort of stabilized a little bit close to the holidays. It took a little bit for them to come down, but they are starting to increase again, but very slowly. Looking at hospitalizations, I just wanted to mention that, generally this is a little bit of a lagging indicator. After cases decreased from our peak in September this last fall, it took a while for hospitalizations to come back down and sort of stabilize as well. So I think it's too early to see, but I think Dr. Carson's presentation was very clear that just the sheer number of cases that we're going to experience in North Dakota, and we know that a certain rate of people are going to end up in the hospital with Omicron, even with Omicron, we're going to see increases in hospitalizations. And even though the rate of hospitalizations may be lower for Omicron, when your sheer number of cases, triple, quadruple, or even go 500%, it's a lot of cases. And so we are expecting to see more pressure being put on our healthcare system. And of course, that's what we're trying to avoid. So, and just looking at today's hospitalization numbers, when I looked at the data this morning, we had 5 individuals that are currently hospitalized that are less than 20 years of age. And then we have 19 that are between 20 and 49 years of age. So it's not just something that impacts older individuals that you generally would expect or think of. We have younger people that are being hospitalized with this particular infection. And then just looking at deaths real quickly, we are at 2,041 deaths as of yesterday, which is too many. But the cumulative deaths by age group here, you can see that those age groups that have been impacted tend to be on the upper end of the age range. But we do have younger people that are dying from this as well. And so it's one of those, it's a disease that can affect anybody. And again, vaccinations are our best bet against reducing deaths and hospitalizations in North Dakota. And then just looking quickly at hospitalizations and vaccination status, you can see here, this is just looking at average active hospitalizations by week. So this is each bar's weekly data, and the fully vaccinated is the red bar, and then the not fully vaccinated is represented by the gray bars. And you can see that the fully vaccinated are just a fraction of the cases that are being hospitalized in North Dakota. And again, that's something that we want to reemphasize. What's also interesting, and Dr. Carson alluded to this, is that Omicron is much better at escaping immunity, whether that's vaccine-induced immunity or natural immunity from previous infections. You can see our reinfection rates have really started to climb, and in the last week we've had over 1,000 reinfections reported. So that is something that we need to keep in mind as well. And again, Dr. Carson alluded to this. Even those who have been had a previous history of disease benefit from being boosted with vaccinations or being vaccinated. Just looking quickly at our variant surveillance in North Dakota, We have been conducting surveillance since late 2021 or mid 2021, and right now, in the last several weeks, it's only been Omicron and Delta that have been reported in North Dakota. Previous to that, it was Delta. You can see here on this graph that on the right-hand side in the red orange color, that is Omicron and the emergence of Omicron in North Dakota. And you can see how it's become the predominant strain in North Dakota. That greenish blue that's in the middle there, that takes up a good portion of the graph. That's Delta, and Delta emerged back in May. We had our first cases. So you can see how this is starting to change. Right now, we've had 415 total Omicron variants confirmed in North Dakota. In this last week, that's up by 205, which is about a 98% increase. Delta, we've had 4,766 total reported. That's up 69 in the last week. That's about a 1% increase. And so the proportions much better, much greater for Omicron and the emergence of Omicron. I do want to talk a little bit about isolation and quarantine. Recently, CDC made updates to its isolation and quarantine guidance, and North Dakota has implemented the updated guidance. So I think the first thing I just want to talk a little bit about is how do you calculate your isolation and quarantine period. When you want to start to pick your start date for your isolation or quarantine, you need to be looking at, for isolation, you need to be looking at what was the first day that your symptoms started. That first day that your symptoms started is your day 0. And then the first day after symptoms is day 1. And then you count day 2, day 3, day 4, and day 5. If you never had developed symptoms, then you would use the date that you were tested. So if you went in and you had your specimen collected today would be your day 0. But if you were tested when you were asymptomatic and then later developed symptoms, that day of symptom onset would become your day 0. And so if I was tested today and then tomorrow I developed symptoms, that tomorrow would be my day 0, and I would start counting from day 0 for my 5-day period. So that's sort of how you do it for when you were infected. If you've been told you've been exposed to somebody or you're a close contact to somebody with COVID-19, how do you start your quarantine period? Well, the last time that you were exposed to that infectious person while they were infectious is your day 0. And so if I had my last contact was today would be my day 0. If my last contact was 3 days ago, that would be my day 0. And I need to know when I had last had contact with that individual. And then I would count there up to day 5. I think the overall theme with the new guidance is that the 5-day isolation and the 5-day quarantine is sort of a minimum that CDC is recommending. Really, to be released from isolation and quarantine, people should be looking at, if I'm isolating because I'm infected, am I feeling better on day 5? Have my symptoms improved? And am I fever free? And if those things aren't true, you're probably not ready to be released. You're not ready to be released from isolation, and you need to probably continue that isolation up through day 10. Same with quarantine. Anytime when you're quarantining, if you develop symptoms, you should seek testing to identify your status, whether you're COVID positive or not. And so, and the idea is that coming out of quarantine, you shouldn't be coming out of quarantine ill. You should be healthy. So, all right. Moving on, just a little bit more on isolation. You know how to calculate your isolation period. What's the recommendation? And again, it's stay home for 5 days and isolate from others in your house if you're able to do that. And part of that is having a well-fitted mask if you have to be around others, even while you're in your own home. You can end your isolation after 5 full days of isolation, and you're fever-free for 24 hours without having to take meds such as Tylenol or aspirin or Aleve or anything like that. And then if that's the case, you can release yourself, but you should continue to take care with being around others and not going places where you might expose others, and wearing that well-fitting mask for that duration of that 10 days. If you never had symptoms, you can end isolation at the end of 5 days after your positive result. The one caveat is if you were severely ill or you have a immunocompromising condition where you have, then you should really consult with your doctor before you end your isolation. And you need to isolate for the full 10 days because we do know that some people can remain infectious even after 10 days. And generally speaking, that's based on disease severity and a person's immune responsibility or response. Just a little bit on the quarantine update. Again, it's the general rule is 5 days. If you're exposed to somebody, quarantine for a full 5 days. And then on day 5, if you did not develop any symptoms, you can be released from quarantine. You can release yourself from quarantine. And you should continue to wear a well-fitting mask for the duration of the 10-day period. You should continue to monitor yourself for symptoms. And at any time during your quarantine period you develop symptoms, seek testing. And if you're test positive, then you would start an isolation period, and then you would go back to the rules for isolation. And if you tested positive, your first day of isolation would be your first day. Day 0 of isolation would be the day you develop symptoms, and you would go 5 days from there. And then at day 5 of your isolation period, you could reevaluate. You evaluate yourself, and if your symptoms are improving and you're fever-free, you could release yourself from isolation. So. Okay, for quarantine, it depends on whether you're vaccinated and up to date or not. And so just a little bit about that. If you're exposed to somebody and you're not vaccinated, then the recommendation is to quarantine for a minimum of 5 days. And you watch for symptoms until 10 days after your last close contact with someone. If you develop symptoms, you should go get tested. So. Just a little bit of information on quarantine, and I highlighted what I wanted to really talk about is that you do not need to quarantine if you come into close contact with someone and you are 18 or older and you have your recommended vaccinations, including your booster doses and any additional primary shots for some of those people who are immunocompromised. You also don't need to quarantine if you're a close contact if you are 5 to 17 years of age and completed the primary series of COVID-19 vaccines. Now, there is a segment of that age group where boosters is recommended if you receive the Pfizer, but not everybody received the Pfizer, and not everybody in that age group would have an opportunity for boosters. And so that primary series is applicable for avoiding quarantine for that 5 to 17-year-old age group. If you had confirmed COVID-19 within the last 90 days and you are now exposed, you would not need to quarantine. If you are symptomatic or develop symptoms, you would still want to seek the guidance of your healthcare provider to see if you may have been reinfections. Reinfections can happen within that 90-day period, but they are rare. I wanted to touch a little bit also on home testing because home testing is becoming more popular and we're starting to get more questions regarding home testing. So the first thing is test results that come from home testing are not required to be reported to the North Dakota Department of Health. Individuals who are testing at home are not obligated to report to us. If they have questions about their testing or what they should do when if they test positive, You know, they can feel free to call our hotline, but they do not have to report to us. People that test at home and they become ill should contact their healthcare providers if they have concerns about their health or their test results, if they have questions about what that might mean. I think what's important here is, you know, there may be situations where it may make sense to consult with the healthcare provider. You know, you're feeling ill and your symptoms aren't improving, or they're getting worse. Then you should consider consulting with the healthcare provider. But also, if your test result maybe doesn't make sense with what you're experiencing, maybe you were named as a close contact, now you're symptomatic, you test at home and it's negative. You know, that could be a false negative. And I think in a situation like that, again, you want to consult with your healthcare provider. People who test positive on a home test should self-isolate and they should follow CDC guidance. And then people who test positive are also encouraged to notify their close contacts. And again, if people have questions about what they should be doing, they can call our COVID hotline and the number is listed there. Just a little bit about influenza. Our influenza season is really taken off. We are seeing a rapid increase in influenza in North Dakota. Cases have come down in the last couple weeks, and I'll show you that in a little bit, but they're still high. And this last week, we had 1,131 new influenza cases reported. That brings our season total just over 6,600. Outpatient visits for influenza-like, about 7.5% of our outpatient visits were related to influenza-like illnesses. And then the number of laboratory specimens that are positive for influenza, that positivity rate for influenza testing, about 8.3% that last week. And then student absenteeism is something that we've been collecting for the last several influenza seasons, and so that was at 18%. New hospitalizations at 35 for the last week, for a total of 133 for the season. And then new deaths, we had one new death this last week and a total of 8 so far related to influenza. And then just looking at influenza, the predominant is influenza A. Of those that we are able to subtype, most of them have been A, H3N2. We have seen some influenza B, but that activity has really dropped off in recent weeks. Influenza reports by week, you can just see there, this is sort of the epi curve by week, how cases have increased. We had a peak here at week 51, right at the end of the year. And then cases have started to come down. Whether that trend will continue or not, I think it's too early to tell. And we may see surges again. It's not unusual to have a couple peaks during an influenza season. It's not unheard of. So I think it's too soon to say that we're out of the woods here with influenza. And just looking at the age distribution of our influenza cases, you can see primarily amongst younger people, ages, you know, children all the way up through young adulthood. And so we're seeing a distribution here in the younger population. So I think if there's 3 things I would ask people to sort of take away with them today. If you have a test that is positive for COVID-19, it's a viral test, you should self-isolate. And it doesn't matter if it's a test from a test site, from your physician, or a home test. If it's positive, you should be self-isolating and following the basic rules for self-isolation. And that basic rule really for isolation and quarantine is we have a minimum of 5 days, and self-release is based on improving symptoms and no fever for isolation or symptoms, or no symptoms for quarantine. So I think the idea is that it's 5 days, but you really have to assess yourself carefully. Your symptoms have to be improving, or you have to be asymptomatic. So, and then the last thing I'll mention, and it will be mentioned by others, vaccination and boosters reduce the risk for hospitalizations for both COVID-19 and influenza. And I think Dr. Carson did a great job of explaining that, and I'm pretty sure Molly will explain that as well. So, and that's all I have, so I'll turn it over to the next presenter.
All right, thank you, Kirby. I am Going to give an update on immunizations or vaccines for COVID-19. And so I'm going to share my screen here. And hopefully everyone can, oops, wrong one here. And hopefully everyone can see my screen. All right, so there has been some recent changes in COVID-19 vaccine recommendations, so I'm going to talk about that today. And then I'm going to give an update on coverage rates in North Dakota. And then just new as of today, we have a new COVID-19 breakthrough dashboard that I want to give everyone a sneak peek of. And so first, just to start with COVID-19 vaccination rates in North Dakota, and this is data that's posted on our website daily. 62.3% of North Dakota adults have at least one dose of COVID-19 vaccine, according to the North Dakota Immunization Information System. The NDIS does not include data from the Department of Defense, so our 2 U.S. Air Force bases, or from the VA. You can go to CDC's dashboard, and that does include data from federal entities. And so rates on CDC's dashboard are higher than what is reflected on the North Dakota dashboard. For adults who have received the primary series, 44.5% of those have received a booster dose. And then for the 65 and older population, 70.9% of those who completed the primary series have received a booster dose of COVID-19 vaccine. For our children in North Dakota, 40.3% of adolescents ages 12 to 18 have at least one dose of COVID-19 vaccine, and 16.3% of children ages 5 to 11 have at least one dose. And so as a reminder, everyone ages 5 and older is recommended to be vaccinated against COVID-19 vaccine. North Dakota rates, sadly, are below the US average for all of these age groups. For example, the US average for adults who have at least one dose is 84.6% right now. Something that's coming up this week, and I don't know if it's on everyone's radar, is that back in August, adults who are moderately to severely immunocompromised were recommended to receive an additional dose of Moderna or Pfizer vaccine 28 days after their second dose, meaning that people who are immunocompromised need a total of 3 doses for their primary series. I think maybe what people don't realize is that these individuals still do need to receive a booster dose, which would be a 4th dose of Moderna or Pfizer vaccine. And so this week, it will be 5 months since that recommendation was made. And so there's a number of people who are moderately to severely immunocompromised who will be coming due in the next few weeks for their 4th dose of COVID-19 vaccine. And so this does not apply to everyone. This is only those adults who are moderately to severely immunocompromised, needing solid organ transplant, being treated for cancer, immunosuppression due to some sort of medication that they're on. And if you're unsure if you fall into this group, I encourage you to reach out to your healthcare provider, and they'll be able to tell you if you're considered moderately to severely immunocompromised and you need the 4 doses. Last week, the CDC made a number of changes to immunization recommendations. So they did shorten the interval between booster doses for the Pfizer and Moderna vaccine. And so for people who received the primary series, so 2 doses of either Pfizer or Moderna vaccine, those individuals are recommended to receive a booster dose 5 months after completing their primary series. That recommendation used to be 6 months and was shortened to 5 months based on data on waning immunity and looking towards other countries who are using a similar interval, and then also, of course, safety. Additionally, the CDC recommended that children ages 5 to 11 who are moderately to severely immunocompromised, those children should also receive that third additional dose for their primary series. And so similar to adults that I was talking about before, if there are any children who are severely to or moderately to severely immunocompromised, they should receive 3 doses for their primary series of the Pfizer vaccine. And then lastly, CDC recommended that all children ages 12 to 17 should receive a booster dose of Pfizer vaccine 5 months after the primary series. And so prior to last week, only adults were recommended to receive a booster dose. And as of last week, that now includes adolescents 12 to 17 years of age. We've been talking quite a bit about booster doses, but I just wanted to show some data and remind everyone that it's just important to be vaccinated. And so on the left, you can see COVID-19 associated hospitalizations in the United States amongst 12 to 17-year-olds by vaccination status. And unvaccinated children are at 11 times higher risk of hospitalization when compared to vaccinated children who are 12 to 17 years of age. And so that's even without a booster. And so what's most important is that unvaccinated children be vaccinated. But as of last week, even vaccinated children can now have access to a booster dose 5 months after they completed their series. On the right-hand side is a graphic that was posted on the North Dakota Department of Health social media this week, looking at COVID-19 hospitalizations amongst children since September 1st. And as you can see in North Dakota as well, almost all, with the exception of one of our hospitalizations in children, have been in unvaccinated or not fully vaccinated children. And so it's critical that if you want to prevent your child from potentially being hospitalized with COVID-19, that you get them vaccinated. And then also on this graphic, just a reminder that pregnant women are at very high risk for severe outcomes from COVID-19 and should also be vaccinated. And as you can see, the vast majority, almost all of our hospitalizations in pregnant women since September 1st have also not been fully vaccinated. And so now I just want to show our new breakthrough dashboard and some of the information that you'll be able to access there. North Dakotans who are vaccinated are less likely to get COVID-19. Dr. Carson explained the vaccine effectiveness with Delta and now Omicron. And yes, it is possible, even if you're vaccinated, you may still get COVID-19. However, even still right now, you're very much less likely to get COVID if you're fully vaccinated, and even more less likely to get COVID if you're boosted. And so definitely encouraging everyone to choose vaccination in order to prevent illnesses in the state. But I think what's most important is that these vaccines are working against severe infections, specifically hospitalization. And so you can see our average hospitalizations per week in the graph here, and in yellow are those who are not fully vaccinated, meaning they don't have individuals who don't have 2 doses of Moderna or Pfizer, or individuals who don't have any vaccines at all. And then in blue are the fully vaccinated, meaning either 2 doses of Moderna or Pfizer or 1 dose of Johnson & Johnson vaccine, and they're 2 weeks past their vaccination. And then in green, which you can barely see on our hospitalization graph here, are individuals who are boosted, meaning after the Johnson & Johnson vaccine, you can get a booster 2 months later. And so if they're 2 weeks past their booster dose, and then for Moderna or Pfizer, again, it's 5 months later. And if they're 2 weeks past their booster dose for Moderna or Pfizer. And so in North Dakota, for fully vaccinated individuals, Those who have the primary series, those individuals are 4.4 times less likely to be hospitalized. And then for boosted individuals, since November 1st, those individuals are 10.9 times less likely to be hospitalized due to COVID-19 compared to somebody who's not fully vaccinated. I think also what's important is looking at the average ages on the right. And you can see these are average ages in years for cases, hospitalizations, and deaths in individuals who are boosted versus fully vaccinated versus not fully vaccinated. And you can really see for hospitalizations, the average age of those who are not fully vaccinated is 57 versus if you're fully vaccinated, it's 72. And then if you're boosted, it's 75. And so I think that just shows that the individuals where we are seeing the breakthrough hospitalizations and deaths, they do tend to be older individuals. And that's why it's important for everyone to get vaccinated. So we're not spreading COVID to older individuals who maybe don't have the best immune response sometimes to COVID-19 vaccines or any vaccines for that matter. And then this is my last slide, and I just wanted to summarize, but I think most of us have kind of said this, but are you up to date on your COVID-19 vaccine? Meaning, have you received the primary series, which is 1 dose of the Johnson & Johnson vaccine or 2 doses of the Moderna or Pfizer vaccine, 3 if you're immunocompromised, and have you been boosted? And so boosters, for people who initially received J&J vaccine, it's a 2-month interval. For people who initially received Moderna or Pfizer, it's a 5-month interval for your booster. But getting vaccinated or getting boosted is going to prevent you from having severe COVID-19 infection. And so you're 4.4 times less likely to be hospitalized if you're fully vaccinated and 10.9 times less likely to be hospitalized if you're boosted due to COVID-19. And then also, of course, just a reminder to not forget your flu vaccine. And all of these will help our community and help protect our healthcare, especially our hospital capacity in the state. And so I'm going to turn it over now to Tim Wiedrich, who is going to talk about COVID-19 treatment and availability in North Dakota. And Tim, you're on mute still.
Somebody had to do it, and I guess it was me. Sorry about that. So let's see if I can get back to my slides now. I believe my slides are up, and so I'm going to continue on. In terms of the drugs that we're about to talk about, therapeutic drugs, I want to just really emphasize that therapeutic drugs are drugs that are taken once someone has the disease. The most important actions that we can take are really in the areas that Molly was just speaking about in terms of vaccine, which prevent the disease. So for the next few moments, as we talk about therapeutic drugs, there are a number. And they are in 2 general categories. One is monoclonal antibodies, and these are drugs that are monoclonally, that are molecules that are produced in a laboratory setting, and their action is to act as a substitute for antibodies that are within our systems. And so whether that's enhancing the existing antibodies or replacing them, that's really the function that they play. And more specifically, what they tend to do with COVID-19 is to help prevent the COVID-19 virus from attaching to the human cells. The other category of drugs are antivirals, and antivirals kill or inhibit the virus reproduction and growth. So two categories of drugs that act differently. Because of COVID-19's pervasiveness and the fact that there is a worldwide demand for these types of drugs, the federal government has moved forward with purchasing large quantities of these newly available drugs, and they're allocating those to the states for further distribution within those states. So for the categories of drugs that we're about to speak about, the only source for actually acquiring these by medical providers is through the federal allocations that come to states, and then ultimately how the states are allocating those drugs to the providers. Now, we're currently in week 13 of those allocation processes. And again, coming back to the monoclonal antibodies, there are currently 4 of them that are going through this allocation process. We have Regeneron and BAM plus E that were earlier on very widely distributed and have been proven effective regarding the Delta variant, but much less so relative to the Omicron variant. Sotro is a relatively new one, and Evusheld is also relatively new. The antivirals, these are 2 new ones, Paxlovid and Molnupiravir, that are being distributed as part of this process. Now, as we're going through more and more Omicron variant within the state, we are soon going to see the discontinuance of Regeneron and BAM plus E, and just reliance on Sotro and Evusheld, because again, Regeneron and BAM plus E, as Omicron is predominantly taking over the state, those 2 drugs are much less effective. And so the levels of administration that occur for the first 3 that are listed under the monoclonals are all IV administered, and Evusheld is a intramuscular injection that's performed. The antivirals are administered in pill or capsule form. If we look at the process then that we're using within North Dakota for how that allocation occurs, we prorate by population to the hospitals. And so whatever population are within a given hospital's city, that's the amount that is being allocated out. And then those cities that have more than 1 hospital are further prorated between those hospitals by the number of their hospital beds. And so that means that out of the 8 largest cities that we have, there are 10 hospitals within those cities, and they're receiving direct distribution on a weekly basis from these allocations. For the remainder of the state, every city that has a hospital is being included in this process, and so that percentage of the population is being held and delivered in a just-in-time environment, so that those hospitals can contact us, and with a matter of hours, the health department distributes those drugs on an as-needed basis. And that's so we can make sure that we don't have pockets that are being held and not being accessible, but that everyone within the state, whether you're in PZIC or whether you're in a large city, has access to the drugs as long as there are quantities that are available. But unfortunately, because this is a new production run with these new drugs that have been developed, the amounts that are currently being produced are very, very small. And so that's the reason for this kind of restricted distribution, that we will have no product being distributed to a provider if they have more than 1 week of supply on hand, because we want to continue to make sure that the product is as widely available as possible until it's consumed. When the future production levels start to ramp up, then we'll start to include additional clinics and pharmacies for this distribution. And that will happen later on, but at this point, there are no projections as to when that will occur. I'm hearing media reports that sometime in the spring that can be occurring, but in terms of official channels, we're not hearing any projections as to the larger quantities that will ultimately be produced. So let's take a quick look then at the allocations, just to give you an example of where we're at. We're in week 13 of this allocation process. The amount that we're allocated for this week is Regeneron is at 84 courses, and a course is the number of pills or injections or however the distribution is occurring that need to be taken to complete a treatment for an individual. So 84 for Regeneron, BAM plus E is 70, Sotro is 72, Evusheld is 168, Paxlovid is 200, and Molnupiravir is 760. With the amount that we have then, and these numbers are inclusive now for week 13 of those allocations, with our state warehouse, our health department warehouse, you can see the quantities that we have available there. And we've also listed the amount of drug that's available within the facilities, the providers, how much they have from previous distributions. And so to quickly walk through that, Regeneron, we have 297 courses, 573 of BAM plus E, Sotro's at 370, Evusheld is 195, Paxlovid is 76, and Molnupiravir is at 476. As we then take a look at those numbers and look at the amount of utilization that it's occurred, and now we're going back to these dates reflect a week's worth of consumption. So the first chart, the first column is the first week in December, and I'm going to skip now to the end of January, the last chart in terms of for the week that we're currently in, and the quantities that are being consumed. You can see that the consumption rate is pretty substantial. And as I previously mentioned, because Regeneron and BAM plus E will likely, starting next week, no longer be distributed to us, the primary monoclonal that we're going to be focusing on will be Sotro. And at 314 consumption rate, but looking at what our distribution has been, what the allocation has been a little bit less than a third of that. We fully expect that we're going to be running out of that drug and others as this process continues. And so if I were to summarize, the most important message that I have, while new therapies are on the horizon and production is ramping up, that there will be larger quantities of these therapies that will be available in the future. Where we're at right now and in the foreseeable short term, it's most important that you obtain vaccination. That's the best course of action to prevent obtaining the disease in the first place, and that these new treatments will be in short supply. And if you have any questions about which of these drugs are the most appropriate, please see your medical provider. Well, that's going to be it for me. We'll go back to you, Molly.
All right, thank you, Tim. Okay, I just wanted to thank all of our speakers today. And we do have some time for Q&A, but before we get into that, I did want to mention that this presentation and webinar will be posted on our social media pages, as well as the North Dakota Department of Health YouTube page for viewing at a later date. I know we did receive that question. So just to start out with the Q&A, and Kirby, I think I'm going to ask you this first question. The question is, if a patient goes in and is being tested for COVID, do we test everyone to see if they have the Omicron variant, or test everyone to see which variant they have, or how does that work in North Dakota?
Yeah, so I think that's good, and I'll just review how we test for variants in North Dakota, how our surveillance system works, at least for testing human samples, people that have been So first of all, testing is not going to be applicable to those people who test by antigen testing, and right now that's over half of the testing that's happening in North Dakota, at least at the most current data. And so for those individuals who have an amplified test and that positive test ends up at our lab, whether our lab did the test or whether a private lab sent it in. If it ends up at our lab, what's happening is our lab is by and large just choosing randomly a number of samples that have to go through whole genome sequencing. So you test positive using an amplified test such as PCR. That positive test, if that's at our laboratory and it gets chosen, it goes through a whole genome sequencing where those RNA bases are actually analyzed. And then once it comes out of whole genome sequencing, that goes to into a system where it gets assigned to a lineage, for example, Alpha, Delta, or Omicron. Okay. So not every sample in North Dakota is tested. We don't have the capacity to test every positive. We are able to do somewhere around 400 or so samples a week that go through whole genome sequencing. Not all of those will be successfully sequenced. Sometimes that fails. And so not all of them come through and get sequenced successfully. And those that are sequenced successfully sometimes don't always are able to be assigned to a lineage. There's just not enough data to make an assignment. So it's not every sample, and the ones that we are choosing right now are by and large randomly selected to help us understand what's happening in North Dakota.
So basically, from the sample that we are doing whole genome sequencing on, we can extrapolate based on that what percent in North Dakota is Delta versus Omicron right now.
Right, and you have to realize that the samples that we have to choose from, although we're trying to pick a random sample from what's available to us, what's at our lab isn't arriving randomly. That you know, and so we have there's some caveats with it, but in general, it gives us a good picture of what's happening in the state. So.
All right. So next question, I think Dr. Carson, I'll ask this to you. How do childhood hospitalizations for Omicron compare to other viruses that we traditionally see, like influenza or RSV?
Yeah, that's a great question. So, I can tell you that my pediatric colleagues fear RSV about as much as any, winter virus in particularly young children. There are about 56,000, 58,000 hospitalizations per year for children with RSV. And that typically is in the younger children. We have no vaccine for RSV. We really wish we had a vaccine for RSV. COVID, about half the states don't really collect good hospitalization data, and pediatrics are best estimates from the states that do, about half the states that do. We've got about somewhere in the neighborhood of 25,000 kids have been hospitalized. It's maybe a little more than that now, probably double that because half the states aren't reporting. So you're in the same ballpark as RSV. It looks to be slightly worse than influenza. When you look at like adolescent hospitalization rates for COVID versus influenza, it's about double. My recollection, I looked at this a while back, but it was about double. So they're all kind of in the ballpark with each other. They're pretty close. We've had, Molly, you can kind of correct me on this, I think in almost 2 years of the epidemic, we've had close to around 700 pediatric deaths. We typically have from influenza around 125 pediatric deaths a year. So if you double that for 2 years, it'd be 250. So we've had a fair number more pediatric deaths associated with COVID. So we have a vaccine for influenza, which we highly recommend in children because these are preventable hospitalizations and preventable deaths. We have a vaccine for COVID, preventable hospitalizations, preventable deaths. RSV is definitely something that we worry about in young children. We really wish we had a vaccine. There are some candidates in the pipeline for that, but they are similar, and COVID is certainly in the same ballpark or even a little worse in some circumstances.
And again, and I know you touched on this in your presentation, it's the concern with Omicron is the sheer volume of cases all at the same time. And so versus flu that's kind of spread out, or we see less cases, we're going to have more cases, which will lead to more hospitalization.
Yeah, if I can, just add to that, Molly, typically in a flu season, the attack rate typically amongst the population is somewhere around 5 to 25% of the population will be exposed and come down with a flu or flu-like illness. We expect the attack rate for Omicron to be just about everybody. I mean, we think this is going to be 80, 90, 95% exposure and attack rate. So it's just much higher volume of cases.
All right, and I think the next question is also for you, Dr. Carson, and we've gotten this a couple times. Many people are aware that in the United States, we have vaccine safety surveillance systems. And so can you talk about the Vaccine Adverse Events Reporting System, or VAERS? And then also, people will hear anecdotally that they had a friend who had a heart attack a couple of weeks after receiving the vaccine, or a stroke. And how do we know if that's due to the vaccine or not, or if this vaccine's safe?
Yeah, so I did see that question pop up. It's a common question. It's a fair question, a reasonable question. So let me share a couple slides with you on this topic. So are you guys seeing that, Molly?
Yes.
Okay. So let's just take a typical day in America. What's the typical morbidity, illnesses, problems, deaths in America? In the United States, we have about 2,200 people going to have a heart attack every day. About 2,500 people have a blood clot every day. Similarly, almost 2,200 people have a stroke every day. About 4,900 new cases of cancer will be diagnosed every day. Now, this is before COVID, right? This is before COVID vaccines. This is kind of baseline what happens every day in America. And about 8,000 people will die. So when you're vaccinating, now we've given out over 250 million vaccines in a fairly short period of time. It's a guarantee that those 2,200 heart attacks, 2,500 blood clots, strokes, et cetera, some of those are going to happen a day or a week or within a month after that vaccine. And so it's not easy to tell, was that from the vaccine or was that just what was going to happen anyway? The only way you can do that is if you can compare a vaccinated group of people to an unvaccinated group of people for those problems, so we can get at the background rates of those things. Now, the VAERS database is what we call a passive surveillance system where people can report in, hey, I think something happened. My grandma had a heart attack, a week after the vaccine. We look for signals in that database, like we're seeing a few more reports of heart attacks, or we're seeing a few more reports of blood clots. That's partly how we got at the blood clot problem with the J&J vaccine. But that doesn't answer the question. It tells us you need to go look at this particular question or problem or issue better with a control group, an unvaccinated control group. Well, that's been done now. So this question of heart attacks, strokes, blood clots, et cetera, has come up. What have we found? There's a big study out of France looking at 3.9 million people over the age of 75, specifically for strokes, heart attacks, and blood clots to the lung. So that's a big group, And now these are big numbers, and they looked at how they compared vaccinated people, how they compared to unvaccinated people, and how they compared to the same time period, 2 weeks after a vaccine versus not in relation to the timing of the vaccine. And they found there was no relationship at all, no increased risks of any of those things in that 14 days after receiving the vaccine or amongst comparison with unvaccinated controls. And another similar, this study was in the US, 11 million people looking at death from anything. So just any cause of death after being vaccinated versus unvaccinated people. And actually, you can see the vaccinated people, and they're trying to tease out why this was, because if you pull COVID out of the equation, which they did, there still was a lowered risk of death in people who got the Pfizer and Moderna vaccine, and a little bit lower in the J&J. So this is just any cause of death. So people kind of worried, well, maybe the vaccines are causing more deaths from other things other than COVID. That's not bearing out in big studies with a control group in many different countries. So this is US data, that was French data. We've got a couple other studies here. This was a big VA study of over 750,000 veterans followed for more than 6 months, pulling out COVID, looking at vaccinated veterans versus unvaccinated veterans. The vaccinated veterans had a lower overall mortality, even if you took COVID out of that equation. So vaccinated people did not certainly have higher, they actually had lower mortality. And in a big nursing home study, not quite as big as these others, but 20,000 nursing home residents were followed for death, heart problems like heart attacks, neurologic problems like strokes. The vaccinated, here again, had a lower mortality and no differences in the other problems compared with the unvaccinated. So, you know, we're just not seeing these problems. The vaccines are just turning out to be remarkably safe.
All right, thank you, Dr. Carson. So we have a few more questions here. Let's see, Kirby and Dr. Carson, you might want to answer this also. There's been a lot in the media about, you know, being hospitalized with COVID versus due to COVID, or dying with COVID versus due to COVID. Kirby, do you first want to talk about how North Dakota is reporting out COVID deaths and hospitalizations? And then I don't know, Dr. Carson, after that, if you'll have anything that you want to add to that.
Sure. I just from a surveillance perspective, for public health surveillance, what we do is we're interested in people who are in the hospital because their COVID is severe enough COVID-19 disease is severe enough to put them in the hospital. The hospitalization, from a public health perspective, the hospitalization is one of the markers we look at to determine disease severity, and it's one of the outcomes that we're interested in measuring. And so what we're interested in is collecting those that have COVID-19 severe enough to cause hospitalization. We do have a team that devotes their work to following up with hospitalizations and reviewing information we collect from hospitals on why individuals are hospitalized. And so we do try to verify that our data is reflecting severe illness versus just being in the hospital with a broken leg and happen to be COVID positive. So.
And Dr. Carson, did you want to add anything onto that about what the differences are nationally? Or I know you've looked at data at all-cause mortality as well.
Yeah, so I think behind that question is I think a very legitimate question, and I think in my mind a somewhat illegitimate question. So sometimes that's spurred by people still minimizing the effects of the virus or minimizing the effects of the pandemic. And I point to people, if you look at just death in the United States from everything. So if we were sort of inflating COVID deaths or COVID hospitalizations, particularly deaths, and putting COVID diagnoses inappropriately on death certificates, we shouldn't see overall death rates in the United States going up, but they went up dramatically in 2020 and into 2021. When you look at our 5-year trends of deaths from all causes, we just had anywhere from 5 to 45,000 more deaths every week throughout 2020 and the early part of 2021. And so the obvious question is, well, what's causing all that extra death? And the obvious answer is that's COVID. And actually, when you look at the death certificates, COVID is almost directly accounts for almost all of those excess deaths in the United States. There is a fair kind of question behind, how do we disentangle this? There's nothing disingenuous about the with COVID from COVID. The problem has come that hospitals, as they're trying to prevent outbreaks in the hospitals, a number of hospitals and health systems have taken the measure of like, we're going to just test everybody in the hospital to see who's got this so we know who to isolate. Now, I've talked to most of the large health systems in North Dakota. Most of them aren't doing this. Most of them are testing surgical patients before they go to surgery, but they're not doing the broader hospital groups. But I think one of the questions was around New York, for example, and Dr. Fauci mentioning that, you know, half the people in New York hospitals are with COVID, not from COVID. We're not doing that in North Dakota. We're not testing like everybody, like some of the other states are and some of the other health systems are. But there was a very nice piece in the Washington Post by Dr. Robert Wachter. He's the department chair of UCSF in California. They tried to disentangle this. So how much of these are with COVID, from COVID? And they noted it's like really hard to tell how much of this is directly with versus from. There's actually a big working group trying to work out how to define that better so that we can explain that, because a lot of people are just getting incidentally tested because they want to find these mild or asymptomatic cases to prevent it. The New York data suggested that about 60% of the hospitalized cases there were from COVID. In North Dakota, I think it's probably a lot higher than that. I polled my hospitalist colleagues, my infectious disease colleagues, my ICU colleagues, and they say they think that it's 95% in North Dakota. If you're in the hospital with COVID on your chart, you're there from COVID, or in the ICU from COVID. I'm sure people kind of question that, but that's what most of my colleagues are suggesting. And then when it's reported on the website, as Kirby said, that's vetted a bit further. But there's nothing disingenuous about this. It's a difficult thing to untangle.
So we have quite a few other questions, but I wanted to make sure we get to some of these key questions. One on treatment. So if somebody tests positive for COVID, when and how should they inquire about treatment, specifically monoclonal antibodies or antivirals? Tim, do you have thoughts on that, or did you want me to turn that over to Dr. Carson?
Well, I'll just quickly weigh in. You need to check in with your healthcare provider. And Dr. Carson, you know, beyond that, do you have anything?
No, I think that's right. I'm embarrassed I should know this, whether the health systems have put up any kind of hotline on this sort of thing. I know that, you know, sometimes going through urgent care can help get you there, but I think calling and checking with your own healthcare provider first, and they're in the different systems all informed on the pathway to get to those treatments. So that's where I would typically recommend starting as well.
Yeah,
but just to expand a little bit further on it, that the healthcare providers themselves know in terms of access to the drugs we talked about, how to get them. But the key for an individual is to connect with their healthcare provider.
Yes, and as soon as possible. So as soon as you get tested, as soon as you have symptoms, because you want to know early in the course of your illness so you can get treated as soon as possible if you're eligible for treatment. We did have a question on masks. Kirby, I know we've been talking about this a lot lately. It's been in the media. Is there a certain mask, if people want to wear masks, that provides better protection against the Omicron variant that you would recommend?
Sure. I think CDC has been doing some foreshadowing on some of this. And right now, the current CDC recommendation is to still have to use a mask that is multi-layered and is tight fitting. And that's the current recommendation. But what we've been seeing in the media is maybe a leaning towards going to an N95 or KN95. And so I think that there's data that's emerging that shows that, you know, there's a better blockage of infectious particles when using the KN95s or the N95s. But at this point in time, the current recommendation is still for a multi-layered mask that is well-fitting. So, and CDC has great guidance on how you can improve the efficacy of that. For example, you know, procedural masks, the disposable procedural masks, you know, putting a cloth mask over that, are tying knots in the ear loops to close gaps around the cheeks and that type of thing. So there are ways that you can improve how well the masks work. But I think the idea is if you got a good fitting mask, use it. So.
And then this will probably have to be our last question. But we got a couple of questions asking us to make predictions about when Omicron will peak in North Dakota, or when we'll see an increase in hospitalizations. Kirby or Dr. Carson, any thoughts on that based on what's happening in other parts of the world or other states?
Well, I can tell you my crystal ball is a bit fuzzy on this. I think we're several weeks. We probably have several weeks before we see a peak here. I'm hoping I'm wrong. I'm hoping it's earlier. But generally, we lag a little bit behind the what's happening in other parts of the United States. And since we were a little bit late to the arrival of the Omicron game in North Dakota, we may be a little bit later in our seeing the peak. But I'll let Dr. Carson fill in.
So I just was reading that the cities in the United States that have been the earliest hit, New York, LA, Chicago, New Jersey, some of the cities in those larger coastal areas, look like they might be peaking. I mean, it's always a little early, to call that for sure, but several of them seem to be plateauing and maybe starting the downhill slide. And most of them started their Omicron surge in mid-December. And so it took about 4 weeks for them to maybe be hitting peak. And that's kind of what has been seen in South Africa and parts of the United States. So if we're really starting our surge now, I would expect us to peak maybe the second week of February. If I had to make a bet on it, I would predict then, and then it'll be another 2, 3, 4 weeks coming down from that. So we're still in for it here for the next few weeks.
All right, and we hit 12:30, so we'll try and get to a few of the questions in the chat that we haven't answered yet, but I want to thank everyone for attending the North Dakota Department of Health Town Hall on the Omicron variant today, and thank all of our speakers. And again, this town hall will be posted on our social media channels as well on the Department of Health YouTube page. And so be on the lookout for that. And again, thank you.